As you said, my name's Tracy Rickards, and I'm a registered nurse. This year marks my 40th year as a registered nurse, which just is a bit sort of mind-boggling when I think about it. But it's been a career full of very interesting things and never a dull moment. So I'm always happy to come and talk. This research that I'm going to talk about, the Mobile Seniors Wellness Network, it was sort of the capstone of my career. And it was a really interesting project, and we did some pretty amazing things, as I will try to elaborate on as we go through the presentation. Um, okay, so um, I'll get to the next slide. Uh, Next, okay. So I'll do a little introduction, and then I'm going to talk about the project planning and how we plan the project itself. A little bit something called Feet First with teamwork, and then some of the outcomes and a very short summary at the end. So in New Brunswick, it's a province with the second highest percentage of older adults in Canada, as I'm sure you all are fairly well aware. 10% live in poverty, 16% are over the age of 65, 27% live alone, 47% live in rural communities, 93% live in private households. And most of the people that we encountered lived rurally, as I'll explain later, and were family incomes of some of the lowest in Canada, and well below the poverty line. Um, So this is just a map to sort of set the stage a little bit, but it shows, as you can see, New Brunswick is down there in the bottom, and it says 22.8%, plus 2.9. So we have 22.8% proportion of the population who are age 65 and older, and it's changed by 2.9% over a period of time. This map is a little bit older, and the statistics demonstrate that we're going to far exceed any of these projections. Um, the New Brunswick Aging Strategy actually suggests that by 2038, older adults will account for 31% of our population. So that's approximately, when I did the math, about 16,000 people over the age of 65 living in New Brunswick. Um, and we add this to the fact that New Brunswick has one of the highest rates of diabetes in Canada at 19% of the population. And then, that sort of sets the stage for a potential disaster, and one of the things that we addressed in the research. Aging diabetes in the rural setting. So, rurality in and of itself provides or presents a number of barriers or challenges, I guess would be better. But many of the people that we spoke to in our project talked about lack of transportation. Either they no longer drove, or they didn't own a car, or they were reliant upon family members to drive them to places. There certainly isn't public transit in rural settings, as you're well aware. They also talked about isolation, and to some degree the cost of medications and diabetic supplies, and that was because we were asking them about those specific things. And then for many of them, the shortage of a primary or a local primary healthcare provider, so somebody in their community, was a problem, or was made more challenging by the fact that they were living rurally. Um, Additionally, they talked a little bit about food, housing, and financial insecurity in living in a rural setting, because especially if you've got transportation issues, you're sort of bound to shop at whatever the local grocery store or convenience store is, and yeah, so they were talking about having challenges with trying to get good food, healthy food, which is very important with people who are living with diabetes. So diabetes in adults is associated with an increased risk of premature death, as we're well aware, reduced ability to function independently, and increased risk of institutionalization. So at about every 3 minutes, another Canadian is diagnosed with diabetes. And diabetic foot ulcers are the most common and most costly in both, in terms of both money and in lives, of the associated health complications related to aging diabetes and to diabetes in the rural setting. Um, yeah. So, what we posed as a research question in terms of planning, project planning, was, does a mobile seniors approach um, to services and foot care for older adults support safe aging in place and an improved quality of life for isolated older adults? And our goal was, we were thinking, gosh, if we could just enroll 200 participants, that would give us enough to actually show some significance in the data that we found. And we were looking for it through referrals from various sources, such as we notified healthcare centers, we notified physicians, we talked to other practitioners in the areas just to sort of say, hey, this research is out there. If you've got anybody who you think would qualify, then please let us know or put them in touch. So pre-identified barriers to aging well in place. As I've talked about before, there was some of we talked about the food insecurity, being able to get access to food, when they're living on a fixed income, being able to access food that they can afford, um, uh, having access to food banks if that's what's needed in order to augment what they've got in terms of their finances. Also, housing, being able to stay in their own home was really important to a lot of them. However, staying in their own home posed all kinds of barriers and problems because as they lost capacity or abilities, things like, having somebody, they needed to get somebody to come and shovel the snow off their front steps or mow their grass or do things like that. Also, housing that had stairs in it became problematic at times, so there's a lot of shuffling in the house to sort of get everything onto one level. I've already talked about the issue of transportation. Lack of access to community services was another issue. Losing health and independence, and social isolation and loneliness. And these were things that knew about before we even started the research. And the research just demonstrated or confirmed for us that these continued to be a problem. So in 2012, the Fredericton Area Community Health Needs Assessment identified the above concerns voiced by older adults who wish to age well in place. And in 2018, the Fredericton Age Friendly Survey found that older adults were most concerned with losing health and independence, and many were also experiencing challenges when attempting to access information about available programs and services. Now, recall that these are all seniors, and so for many of them, the technology piece was a real problem. So some of them didn't know how to use a computer. Few of them had Wi-Fi or internet access. So, being told that they could fill out a form on the internet was particularly not helpful at all. Isolation is a challenge for many older adults, and especially those living in rural areas, and it has been linked to increased rates of depression, cardiovascular disease, dementia, and premature death. And then the home visits that we did were a vital aspect of the Mobile Seniors Wellness Network project, as many older adults struggle with transportation barriers, especially during the winter months. And I think that the fact that we made home visits and spent quality time with each of the participants was a really important and beneficial component of the research that, we thought it might help, but we didn't appreciate the extent to which it was going to help when we got rolling with this. So diabetes in New Brunswick, as I said earlier, we have one of the highest rates of diabetes. We have the highest prevalence of diabetes at 25%, is those aged 65 and up. I've already mentioned every 3 minutes somebody's diagnosed with diabetes. The diabetes complications are associated with premature death and reduced lifespan by anywhere from 5 to 15 years. Diabetic foot ulcers are one of Canada's top 5 most costly conditions, and I'll elaborate a little bit more on that as we go. And with proper preventative care, 80 to 85% of all diabetic foot ulcers can be prevented. And that's probably the most important message that I can put out there. So it's not a new health concern. New Brunswick and Newfoundland are tied with the highest rates of diabetes in Canada. So being top of this scoreboard is not where we should be as a province. A vital shift in the New Brunswick healthcare system mindset is required as a proactive health promotion focus needed to address the long-term demands of managing diabetes care in New Brunswick. In 2020, it was estimated that 13% of the New Brunswick population was living with diabetes, and at this time, there was also a prediction that by the year 2030, this number would increase to 17%. Unfortunately, within 2 years of this prediction, New Brunswick has already exceeded the 17%, reaching 19% of the population living with diabetes. And the newest projections now is that diabetes prevalence in New Brunswick will increase by 25% over the next 10 years. However, based on the precedent, based on what I've already explained, we can probably hypothesize that this 25% will be realized and exceeded sooner than expected, which is significant. So currently, the highest prevalence of diabetes is among those who are 65 years and older. Diabetes in this group is associated with an increased risk of death, reduced ability to function independently, and increased risk of institutionalization. As we know, diabetic foot ulcers are the most common costly complication of diabetes, negatively impacting people's finances and quality of life. Diabetic foot ulcers will affect an estimated 15 to 25% of diabetics in their lifetime, and many DFUs will result in amputations. When a person with a diabetic foot ulcer requires admission to the hospital, the cost to our healthcare system is more than 50% greater than the cost of a non-diabetic patient admitted to the hospital with a foot ulcer. So the average diabetic foot ulcer admission cost is about 22,754. It's probably more than that. This was from when we did the research, which was a couple of years, 2 or 3 years ago. While the admission of a patient without diabetes with a foot ulcer is about 8,000. So a difference between 22 or almost 23,000 and 8,000. So there's a significant difference in the cost of treating a foot ulcer. The cost difference makes diabetic foot ulcers one of Canada's top 5 most costly conditions. In 2022, diabetes directly cost the New Brunswick healthcare system $110 million, and this cost will only increase in correlation to the rising prevalence of diabetes in New Brunswick. We cannot really afford to avoid addressing this healthcare crisis, but new and innovative approaches are required, such as the Mobile Seniors Wellness Network model of delivery of care. Research shows that improved foot screening for diabetic ulcers can result in long-term cost savings and increased quality of life for adult seniors. With proper preventative care, 80 to 85% of all diabetic ulcers can be prevented. These facts speak to the value of the foot care nurses' time spent with older adults living with diabetes in an ongoing long-term capacity, such as the provincial Mobile Seniors Wellness Network program. Additionally, I just want to, Canada has some of the lowest rates of high-risk diabetic foot screening among the US, the UK, the US, New Zealand, Australia, and Germany. And in 2007, and that was when it was last investigated, less than 25% of the New Brunswick population was receiving the minimally recommended care for diabetics, which includes at least one or more hemoglobin A1C, urine for protein, dilated eye exam, and a foot exam by a healthcare provider within the last year. So that's the gold standard, the bar upon which the Canadian Diabetic Association says we need to be treating everybody by. And most of the people that we spoke to when we asked them about any of these had not had any of these things, or maybe had one of them in the last year. Okay. So the overview. So it focused on Zone 3, which is the biggest zone in the province. Our Mobile Seniors Wellness Network project was a person-centered, multidisciplinary mobile health and social support services to address social isolation, frailty, and vulnerability while supporting aging in place for older adults living in New Brunswick. Our research area was within Health Zone 3, which is the largest within the province. And the New Brunswick Health Council defines this zone to include the Fredericton and central New Brunswick areas. Fredericton is the capital city with all the amenities of a busy urban area. The central New Brunswick region primarily consists of rural villages where the population is comprised mainly of older adults. Approximately 17% of the central New Brunswick area live within low income levels. This area has elevated rates of chronic disease such as asthma, arthritis, diabetes, and emphysema and COPD. Most of the population have access to a primary care provider, 90 says 93.1%, which is awesome. And the healthcare services provided were highly rated in the primary healthcare survey done, though access to the services was limited. On the map on the screen that you can see, there the blue pins, the communities our team traveled to for home visits. At the beginning of each day, our team started at the Fredericton Downtown Community Health Center and drove as far as McAdams, Centerville, Doketown, Chipman, and anywhere in between. Approximately 50% of our population lived in a rural community within about 90 minutes drive of Fredericton. Also, the research took place between November of 2020 and December of 2022 during the COVID pandemic. So that required some very fancy readjusting of our project overview and our project plan. So, in order to maintain, protect the health of the elderly people that we saw. We used all of the personal protective equipment that was suggested by Zone 3 and Horizon Health at the time. So our inclusion criteria, we sought to address the gaps in the healthcare system relevant to older adults and to overcome barriers to aging well in place where and whenever possible. And a focus on socially isolated older adults in both urban and rural areas was vital, along with the goal to improve foot health, especially for those living with diabetes. Another important goal included a decrease in the self-reported incidence of loneliness and social isolation with an increase in support access to services for older adults and caregivers. The older adult participants were recruited through referrals from primary care providers and self-referrals, including those from family and or caregivers. And I can tell you, once the word got out that there was somebody who, a group of people who were doing free foot care, it was no problem for us to get our 200 people. Important to note that our Mobile Seniors Wellness Network project took place during that global pandemic, and we maintained strict infection control protocols as per Horizon Health Authority during the pandemic for our home visits. Many of our older adults that we saw were so pleased to see us and to have us in their house doing in-home visits due to the concerns or anxiety about leaving their home and the risk of exposure to COVID-19 virus, but also because very fewer people visited them. So they were frequently much more isolated than we could ever have imagined. Okay, so we received ethics approval from the University of New Brunswick and Horizon Health Network. As I said, we were hoping to enroll 200. We really wanted to get to 200. In the end, we enrolled 366 seniors living within the 90-minute radius of the community health center. And of those 366, 313 people completed the study. We lost some people because it became very clear that they were just in it for the free foot care and they didn't want to participate in any of the other things that we were doing. We lost a couple to death because we're working with seniors, so that was inevitable. Yeah, so indiv individuals with or without chronic wounds, including diabetic foot ulcers, was the other thing that we were looking for. So, are using a novel foot care strategies as a tool for engagement in rural settings, incorporating the mobile multispectral near-infrared spectroscopy, which I will talk about later, the imaging technology into a community-based foot care initiative for older adults in remote areas to support aging in place. Yeah. So that fancy words that I just said there. Mimosa Scanner is the sort of short version of all of that. And I will talk about that as they were our sort of industry partner. So it takes a village. So we had in our project, we had foot care registered nurses, and we were very clear that we wanted registered nurses because, and we know that we're very well aware that there are a number of great licensed practical nurses who also do foot care, but we were wanting the scope of practice of the registered nurse in this project. For their critical thinking skills, for their leadership, for their, innovative ideas around how to solve problems. So each of the foot care nurses were going to do 6 visits with intervals of about 4 to 6 weeks. So we had patients, participants with us for several months, and that really depended on the foot care assessment findings. So sometimes the intervals had to be a little bit shorter because the foot was in such difficult or challenging condition, and sometimes we could go, to 6 weeks if they were in really good shape. We also had registered social workers on the team, and they did a minimum of 3 home visits, one at baseline, so one when they were first admitted to the project, one at 3 months, and then one at 6 months, and then additionally as needed. So again, depending on the status of the patient or of the participant in the research. The registered social workers saw some of these people only 3 times, and some of them saw them on a weekly basis because they were, either their living conditions were really tenuous, or there was things that they needed, or it just took some time to get all of the things so that they were comfortable living at home alone. We also had access to an occupational therapist, which was great because many of these people in home needed a little bit of adaptation for, like, even just a raised toilet seat, or a shower chair, or a new railing for a set of stairs, or so the occupational therapist was really helpful in providing those kinds of supports. And then we had also an access to a dietitian who provided written information related to nutrition for older adults, and especially older adults living with diabetes. We approached each situation with a person-centered, critical thinking, proactive, and holistic approach through the lens of the determinants of health, knowing that optimal outcomes could only be achieved through collaboration and conversation with the older adult. Each older adult was assigned to a foot care nurse and a social worker, who then consulted with the occupational therapist and the dietitian as needed. The nurse and the social worker and the occupational health therapist made home visits. However, the dietitian only provided written material for the adults' needs. And then further education was completed by the registered nurse. So the social worker did completed assessments for us. So they did the brief patient health questionnaire, they did the geriatric anxiety inventory, the de Jong-Gierveld loneliness scale, the pictorial fit frail scale, the Montreal cognitive assessment. So these were tools that have been used before that we wanted to get in order to get a sense of, how were these seniors doing with living at home alone? Were they indeed anxious or lonely? What was their fit frail scale? And did we need to, it gave us some more information to use in order to put things into action. The actions that the registered social workers did was they accessed government programs. Frequently, people didn't know that they were eligible for some programs, and so that was a lot of their time was spent doing that. Mental health and wellness interventions, evaluation of home care, support service needs, and to assist with some provincial home repair grant applications. They consulted and referred to the Department of Social Development, Adopt a Grandparent Program, the Paratransit Registration, New Brunswick Housing Authority, Stepping Stone Senior Center, and the multidisciplinary team members that were within our team. Just looking to see if there was anything else. Communication between The social worker and the nurse was vital to ensure effective collaboration and to enhance positive outcomes for the older adults. Housing, food insecurity, home care needs, transportation, and social supports were key areas to focus on in most situations that they encountered. So for the foot care registered nurse, the assessments that they did was the foot risk assessment. They did an in-low 60-second diabetic foot screen, which is sort of one of the gold standards, the benchmarks. They did a falls efficacy scale, a diabetic knowledge questionnaire, and the World Health Organization quality of life questionnaire. Um, the great thing about the 45 minutes to an hour or more that they spent with each of the patients was that they provided a huge amount of education. So they consulted with the diabetic education clinic, the dietitian, EMP physiotherapy, occupational therapist, respiratory rehab program, wound care and infectious diseases specialists. But the nurses also talked about, what do you need to have, like what's the appropriate footwear that you need to be using both inside and outside in order to protect your diabetic feet. What are you eating? What kinds of exercise are you getting? Are you sleeping well? So there was all of these things that they were sort of, while you're doing the foot care, you have a conversation with the person and talk about all of these things, which the seniors felt was very helpful. Um, the foot health and foot care management was according to the Canadian Diabetic Association recommendations, the diabetes and self-care management. We did diet and nutritional needs. We looked at wellness and medication. So we always asked about what medications they were on, how long they've been on them, did they know why they were on them. The some of the more challenging moments that the nurses had were when somebody said to them, "Well, yes, I'm on a medication, but I can't really afford it, so I cut it in half and only take half a day instead of the full." And we encountered that so many times, and that was really problematic because we knew how important the medications were. So that's when we consulted with the social worker to say, can we do something about this? Can we find a way to help them to afford the medication that they need? And we also made sure that they had safe use of ambulatory aids such as walkers or canes, grab bars, and that kind of thing. I think that's everything. Yeah, so the foot care nurses had another unique opportunity through a collaboration with our industry partner, so the Mimosa Diagnostics, and this was developed by Dr. Karen Cross. To augment the foot risk assessment with the use of a new and innovative technology called the Mimosa Pro Scanner, which is a near infrared multispectral imaging device. And it was sort of like a cell phone essentially with a camera on the back of it, an external camera that was attached to it that picked up pictures that showed us temperature transitions on the foot, tissue temperature, and oxygen saturation. So it gave us an idea of when there was circulation problems or potential circulation problems, and it also showed when there was a wound, what the wound looked like, and how big it was. Because visually you could see it with your eyes, but with this camera you could see it much better, and you could see like a little bit of depth into the tissue, and it was often much bigger than what the eye saw. So there's Dr. Karen Cross and there's the camera. So it was a portable handheld device. It was non-invasive vascular assessment tool. And the images provided a visual of a thermal and tissue oximetry, which can assist the nurse to determine next steps in wound management of a diabetic foot ulcer in the home. So they would take pictures of nine different planes, so 9 different pictures, and send those up to Dr. Cross, who would then look at them. And if she saw something that she was really alarmed by, then she would alert us, and we would then act on that. But the other thing about these images is that the seniors themselves really enjoyed the pictures, and they were every week they were excited, or every time that the nurse visited, they were excited to see the transition or the progress that was being made with their wound, or what their foot was looking like. So that was, there was a lot of, it was a great tool to use in order to get patients to engage in their own health and what was going on with their feet. I'm going to do a little bit. I got two different clients that I'll talk to, but from a blister to an amputation. This is Elliot, a 58-year-old man who has type 2 diabetes and a chronic diabetic foot ulcer. And his medical history is complex and includes end-stage renal failure, hemodialysis 3 times a week, heart attack, atrial fibrillation, angina, coronary artery disease, hyperkalemia, necrotizing fasciitis of his abdomen in 2021, hypertension, dyslipidemia, chronic back pain, diabetic neuropathy, current right leg cellulitis, gout, restless leg syndrome, severe osteoarthritis in his right knee, sleep apnea, and then he had a right arm AV fistula for his hemodialysis. So he's only 58. He had a lot going for him. January the 26th, 2022 to February the 24th, 2022, Elliot was hospitalized due to necrotizing skin and soft tissue infection on the lateral aspect of his left midfoot, which started as a blister, which is, you can see that red hot spot in the middle of that picture. That's where the wound, the dark blue thing is where the wound actually was. Post-discharge, Elliot continued to receive at-home support for wound care weekly from the community health nurse, while his wife did Elliot's wound care every 2 days and as needed. He continued to attend the wound care clinic monthly to be seen by a vascular surgeon for wound assessment, sharp debridement, and dressing changes. The extramural physiotherapist furnished him with an offloading Darko boot, a four-wheel walker, and education as he was at high risk of falls. The occupational therapist, supplied adaptive tools as Elliot struggled with activities of daily living due to severe peripheral neuropathy, shortness of breath with minimal exertion, and limited range of motion. Maintaining his independence remained important to Elliot, even though it was limited. He was pleased to have received approval for a mobilized wheelchair through the assistance of the OT and eagerly awaited its arrival. So he was admitted to our program June 23rd of 2022. And the foot care nurse focused on maintaining optimal health of the senior's feet as skin integrity was significantly compromised due to peripheral vascular disease, diabetic neuropathy, edema, dryness. He and his wife were receptive to education, addressing self-care and diabetic feet and the importance of properly fitted footwear, both indoor and outdoor footwear. The use of the Mimosa scanner became a valued aspect of the assessment as Elliot and his wife looked forward to the visual confirmation that his diabetic foot ulcer had potential to heal. Due to his visual impairment, Elliot was unable to see the diabetic foot ulcer clearly. Thus, the Mimosa Pro scanner profile photos of the foot bolstered his optimism and provided clear confirmation that their diligent wound care was effective. In June of 2022, the DFU measured 2 centimeters by 1.6 centimeters with a Sinbad score of 5, and the Sinbad score goes from 0 to 6, 0 being nothing, 6 being the worst thing you can do. He'd had a score of 5. At the end of the project in January of 2023, Elliot's diabetic foot ulcer had demonstrated healing with a decrease in size. And when we left him, it was 0.7 centimeters by 0.8 centimeters, and his Sinbad score was 3. So this couple was transferred to the Fredericton Downtown Community Health Clinic, Foot Care Clinic, as they wanted to maintain the overall improved health of their diabetic feet. It was interesting to watch the progress and to see how much he was willing to be a part of the solution and look for ways to continue to get better. It's just a callus. This was Bob. He was an 80-year-old male, retired from the military, who lives with his wife, a retired nurse, in a rural community about an hour's drive from the closest healthcare. He had a stroke in 2020. He relies on his wife for transportation and assistance with his foot care. In spring of 2021, when his wife was doing Bob's foot care, she noticed that the chronic callus on the left hallux was oozing pus. And that's the picture that we've got there. Bob contacted the healthcare center for an appointment, but he stated that it took a few weeks for the wound to be assessed by the primary care provider. This clinic visit resulted in oral antibiotics and a referral to a specialist and reassurance that from the primary care provider that it was just a callus. The specialist assessed the wound a month later and confirmed the diagnosis of a callus. Bob's wife resumed daily wound care of the foot with reassurance that it was not medically worrisome. Bob was enrolled in our project in October of 2021, and the foot care nurse assessed the wound, finding that a callus on the left hallux with an opening and purulent drainage. So protective sensations were intact, and Bob expressed no pain in the wound area. With assistance from the foot care nurse, Bob was referred to a vascular specialist who debrided the wound and provided new prescription for orthotics. At the next visit by the foot care nurse, Bob expressed worry and frustration. He said, "The doctor told me that at the second visit that I might end up losing my toe or my foot because it was taking too long to heal and because it took so long to get it looked at." So this is one of those situations where he needed to have been seen far earlier than we did, far earlier than he did with in the other sort of more formal journey through the healthcare system. Um, During the nurse's ongoing home visits, Bob's wife reported that it feels like the wound was improving every day. On a midpoint visit from the nurse, the foot care nurse, she noted that there were three new reddened areas with skin breakdown and scabs on Bob's right foot, along with a bilateral decrease in sensation. Bob was unaware of the new wound areas. Education paired with quick and early treatment resulted in this area healing quickly without progressing to a new diabetic foot ulcer. The foot care nurse focused on education along with updated referrals for wound debridement and community wound care. Upon the project's completion, the foot care nurse arranged for him to continue to receive foot care close to home, along with the expectation that Bob would continue to be followed by the vascular specialist at the wound care clinic and a community nurses to do the diabetic foot wound care. At the time of discharge from the project, his diabetic foot ulcer was estimated to be 80% healed. Bob's hemoglobin A1C was 9.6 at the time of enrollment and into the project, and it had decreased to 7.7 upon completion with improved glucose monitoring, medical adherence, and education. On check-in, 3 months following the completion of the project, we were looking for new photographs of his feet for a conference that we were going to. Unfortunately, the foot care nurse noted that Bob was no longer followed by the vascular specialist or the community health nurse for wound care. Plus, Bob had not followed through with the ongoing foot care with the alternate provider. So, unfortunately, the diabetic foot ulcer had regressed and had signs of reinfection upon the foot care nurse's examination. And once again, she connected Bob with a vascular specialist at the wound care clinic and rescheduled professional foot care for him. So it was a little frustrating to see that, all the good work that we had done while we were in there was essentially gone within 3 months of our being there. So, these are just some of the things that we gathered from patients when we did a sort of an exit interview with them at the end of the project. So I wish it was permanent. It's good for seniors. All the knowledge I learned, having my feet done, those were positive things. I feel better to manage my foot health. The nurse helped by teaching me how to manage it and by listening to me. And from the social work aspect, you came to at a time when I needed someone to talk to. It was nice to have someone who was there to listen and to give extra support because we all need to be heard. So our findings were that 6% were living with an active diabetic foot ulcer, and no one was re-hospitalized or hospitalized due to that diabetic foot ulcer during the time of the project, which was good. No new foot wounds were developed during the project, and no amputations happened. After 3 visits by the foot care nurse, the INLO scores were significantly lower, which was good. Depression scores after 3 months were significantly decreased. Fear of falling was decreased through the team's interventions. Loneliness scores decreased after 3 months, and the mean anxiety scores decreased significantly. As I said earlier, 366 people were enrolled, 313 completed all of the visits. The average age of our participants was 75.6 years of age, and the diabetic prevalence 44%. So 44% of those 313 people were diabetic. Slightly more in women than in men, 58% of women, 42% of men. 47 were married or had been married. 53% were living alone. 60% had high school or less in terms of education, and 45% were living well below the poverty line. So the study our research demonstrated that improved foot screening for DFUs can result in long-term savings and increased quality of life for older adults. With proper preventative care, 80 to 85% of all the diabetic foot ulcers can be prevented. Anecdotally, we heard about the value of good home care, the ability to access and pay for home care, and the lack of home care in many of the communities. Our participants were far more interested in staying in their own home, but found over time that became harder to do because of the social support network that wasn't robust enough to support their wishes. We found that most of the time the cost of home care was still far less than the cost of the ALC bed or a long-term care bed.